but put it on slideshow.
All right. I hope it's okay now.
Yes, and you are quite clear. Go ahead.
All right. Good evening, everybody. I'll be leading the discussion on cardiac transplantation. This is the outline that we're going to be using for this presentation. Introduction, cardiac transplantation is the treatment of choice for many patients who have end-stage heart failure and are symptomatic despite being on optical medical therapy. One of the things we used to rattle then in part one is that you must, when you are doing a cardiovascular station, is that you must reach cardiac transplantation. That if you don't reach cardiac transplantation, you didn't finish management of heart failure. So it represents the last option for treatment for patients who are still symptomatic despite optimal medical therapy. It's actually the gold standard for patients with advanced heart failure who have both poor functional capacity and prognosis, despite being on goal-directed medical therapy and device-based therapy. It is generally considered to increase survival and improve the quality of life in this group of patients. By way of history, cardiac transplantation has actually evolved over the past century. The first attempts at transplantation were experiments done by scientists. These people were actually physiologists, Carrel and Guthrie. They actually received a Nobel Prize for physiology because of their work in transplant patients, not just hearts, but transplants in general, kidney transplants and all that. So over the years, different individuals progressed, including the first person to perform in a successful heart transplant, although it was in a dog, was Norman Shumway, and that was in 1957. The first successful cardiac transplant in a human being was performed by a surgeon called Christian Barnard in Cape Town in 1967. The patient he used was a 54-year-old male whose heart was irreparably damaged by repeated myocardial infarction. Okay, and they extracted the heart in the adjoining theater room and implanted the heart in this 54-year-old male patient. Okay, it's important for us to know what are the causes of heart failure that lead to transplantation. Of course, the two commonest are non-ischemic cardiomyopathy and ischemic cardiomyopathy, that's coronary artery disease. Those two are the commonest, okay, dilated cardiomyopathy and coronary artery disease. Other reasons for transplant include complex congenital heart disease. Of course, this complex congenital heart disease has to be not amenable to surgery or other palliative measures. Okay, restrictive cardiomyopathy, hypertrophic myopathy, and of course, these days there are now patients who require retransplantation after their initial transplantation. There are basically two types of cardiac transplantation. It could be autotopic or heterotopic. Autotopic simply means that the recipient's heart is removed and the donor heart is implanted. Heterotopic means that the recipient's heart is left in the chest and the donor heart is implanted by the side of the recipient's heart. The donor heart is actually gotten after brainstem determined death or circulatory determined death. Of course, someone cannot survive with a heart, so a heart must be given by somebody who is brain dead for another person to use it, for it to be implanted or transplanted into another individual. This I need help is a simple mnemonic to remember the red flags, because we need to know at what point you refer a patient to an advanced heart failure center. Okay, so advanced heart failure centers are those centers that have the capacity for both device therapy and device therapy, assist devices, and ultimately ending in cardiac transplantation. So I need help. I simply means previous requirement for inotropes, okay, either previous or ongoing need for inotropes. N is NYHA class 3 or 4. N is also high natriuretic plasma levels, high levels of NT, proBNP, and BNP. E is worsening liver or kidney function. E is end organ damage, actually. That's the E. So it's typified by worsening kidney or liver function due to heart failure. E is EF. The second E is ejection fraction. So EF less than 20%, those are the patients you also begin to consider. Then D is ICD. The person requires recurrent appropriate defibrillator shock. So these shocks are recurrent and they are appropriate. That means they are not as a result of device malfunction. Then H is 2 or more episodes of worsening heart failure, persistent admission for worsening heart failure. E is persistent fluid overload or increasing diuretic requirements. While L is blood pressure, systolic blood pressure persistently below 90 to 100. Then P is intolerance to disease-modifying drugs. Okay, so this is the mnemonic. So these patients that have one or more of these things should be referred to a center that has capacity to manage advanced heart failure. This is just what I've just talked about. I need help. Inotropes, N, NYHA, and natriuretic peptide. E is end organ dysfunction. The second E is ejection fraction. D is defibrillator shocks. H is hospitalizations. Then E is edema or escalating diuretics. L is hypotension, low blood pressure. Then P is need for continuous prognostic medication. That's P. So according to cardiopulmonary exercise testing, advanced heart failure, we usually define advanced heart failure according to, it's not just about the physical parameters, it's also about how much the patient is able to do. Okay, and peak volume of oxygen is actually the main parameter to consider in this set of patients, as is related to the functional capacity and the prognosis of such patients. Peak VO2, I will define it, is defined according to the Fick equation as the product of cardiac output and arteriovenous oxygen difference at peak exercise. So this establishes the limit of the cardiopulmonary system. Okay, so later we'll see the VO2 of patients that will qualify or that will qualify actually for advanced heart failure treatment, including cardiac transplantation. So also another thing used in assessing a patient who will need cardiac transplantation is what is called the heart failure prognostic scores. There are two that I saw in one article on NCBI. There's the Seattle heart failure model and the heart failure survival score. These are the most widely used heart failure prognostic scores, although I think there are more, but these are the two most widely used. So for the Seattle heart failure model, a patient who has survivorship of less than 80% at 1 year is considered generally as a reasonable cutoff for listing a patient. So this is like a list of parameters, okay, that helps the clinician to decide, does this patient qualify or not? So if the survivorship, according to the Seattle heart failure model, is less than 80%, it's a reasonable cutoff for listing for heart transplantation. This is a class of recommendation. It's a 2B class of recommendation, and it's expert opinion. Level of evidence is C. However, it should be regarded that this Seattle heart failure model tends to overestimate survival and is limited in younger patients with advanced heart failure. So, however, but the other one, the heart failure survival score, when it has a low risk, described as a score greater than 8.1, signifying a 1-year survival of 93%, this rules out the need for heart. So if you combine the two scores, you may get a better outcome. Okay. So how do we evaluate patients for transplants? The first thing is we need to be sure of the indication. Why does the person need a transplant? The second thing is there need for a combined organ transplant? Do we need a heart and a lung transplant? Is there severe cardiorenal syndrome prompting the need for a heart and a kidney transplant? So those things are also important, okay? Then the next thing is to review for contraindications, absolute contraindications or relative contraindications. So what are the indications for cardiac transplantation? Number one is patients who have cardiogenic shock requiring continuous intravenous inotropic support or circulatory support with an intraarterial BP device or mechanical circulatory support. That's maybe they need an assist device to maintain adequate organ perfusion. So most patients who require inotropes at home, okay, they will already be on the transplant list. So patients who are on an intra-aortic balloon pump, okay, or patients who have mechanical circulatory support, they should already be on the transplant list. The patients who NYHA4 and NYHA4 refractory to optimal medical and surgical therapy, including use of devices. So these patients should have been checked if they need a CRT. Okay, they should be on a CRT and watch if they improve, if CRT improves their symptoms. If they need an assist device, okay, they should be given that and all that. So every other thing has been tried, and the patients are still refractory to optimal medical and surgical therapy. For valve lesions, valve surgery should be explored, valve congenital lesions, congenital repair, and all that. So every other thing should have been tried before you can say this patient qualifies for heart transplantation. So the peak VO2 use for patients who are not on beta blocker, okay, either they are intolerant for one reason or the other, maybe bradycardia. Okay, the peak VO2 should be less than 14 mil per kg per minute. This is on cardiopulmonary exercise testing. For patients on a beta blocker, the peak VO2 is less than 12 mil per kg per minute. Okay, now for patients who are younger, who are less than 50 years old, or for women, okay, peak VO2 less than 50% of the predicted for the age of that particular person can be used as an alternative criteria. These are the absolute indications, okay? Then, of course, I've talked about the heart failure prognosis scores. They favor listing, okay, but they are not to be used as sole criteria for listing, okay? But you can use it to buttress your point that these patients should be on the transplant list, okay? Other things that are indications are intractable or severe angina in patients with coronary artery disease, not amenable to PCI or revascularization. There are patients who have severe coronary artery disease, multi-vessel disease, okay, that you want to do. How many cabbages can you do? You can't do 5-vessel cabbage, or they have obstructions at very, very distal points that cannot be amenable to PCI. So these patients should be considered, and they now meet the other criteria. Okay, they should be considered for cardiac transplantation. This also includes patients who have transplant coronary artery disease. This is known as cardiac allograft vasculopathy. They are also considered for retransplantation. The patients who have intractable life-threatening arrhythmias, okay, arrhythmias that are unresponsive to medical therapy, that are unresponsive to catheter ablation, unresponsive to surgery or ICDs is an indication. Then select patients with restrictive cardiomyopathy, hypertrophic cardiomyopathy in NYHA class 3 to 4 are also to be considered for cardiac transplantation. What are the relative indications? So these ones I said are the absolute indications. So this now will go to the relative indications. Patients with heart failure causing a major limitation of daily activities despite medical therapy. So here, including patients who are on a beta blocker with a peak VO2 of 13 to 14 mils per kg per minute, or less than 55%. You know, the other one, we said it was 14 mils per kg per minute. So it's down a little, is a relative indication. Okay, then if there is recurrent unstable ischemia, not amenable to other intervention, recurrent instability of fluid balance or renal function, okay, and this is not due to patient non-compliance with medical treatment. Now, the following are insufficient indications. Low ejection fraction on its own is not an indication, okay? Then if there's a history of functional class 3 or 4 symptoms, not an indication. And if the peak VO2 is greater than 15, greater than 55% predicted without other indications, it's insufficient to list a patient just on this. What are the absolute contraindications? If there is a systemic illness, a patient has a systemic illness with a life expectancy less than 2 years, okay, so the patient has malignancy, whatever it is that makes him to have a life expectancy less than 2 years, a contraindication. patient has irreversible pulmonary hypertension, it's a contraindication. If the patient has clinically severe symptomatic cerebrovascular disease, if the patient has active substance abuse, a drug addict, tobacco use, alcohol use, okay, the patient should first of all be rehabilitated and watched before the patient is considered for cardiac transplantation. If the patient is unable to comply with medication, okay, in fact, this particular one is actually a very important one, because I've seen, like, there was a patient that I encountered one time who had cardiac surgery and could not afford to take warfarin. She had cardiac surgery on a missions basis. Okay, so everything was done free. But this person could not eventually afford to buy her warfarin. And of course, she eventually had a stroke and died. Okay, so inability to comply with drug therapy is very important, because these patients must be on immunosuppressives. Okay, then multisystemic disease with severe extracardiac organ dysfunction. So if a patient has amyloidosis, okay, you have to be sure that the amyloidosis in other sites is treatable before you consider a transplant. Okay, before you consider it. So a patient has maybe carcinoid syndrome, whatever it is that has systemic manifestations, you need to be able to look at the patient holistically. Is also an absolute contraindication. Relative contraindications: age, elderly patients more than 70 years old, obesity, okay, diabetes with poor glycemic control, HbA1c of more than 75, okay, despite optimal efforts, or end organ damage. Okay, person has surely nephropathy, okay, other end organ damage apart from non-proliferative retinopathy. If there's irreversible renal dysfunction with an eGFR of less than 30 mils per minute, you don't want to do a cardiac transplant, except you do a combined heart and kidney transplant. Then neoplasm, okay, any malignancy, depending on the malignancy, actually, then active infection. These are relative contraindications. Others include acute pulmonary embolism within 6 to 8 weeks, tobacco use within 6 months, recent substance abuse or drug or alcohol abuse, inadequate social support. These patients will be in the hospital for a minimum of 3 weeks, so they need adequate family and social support. Or if they have cognitive behavioral disability, that will prevent them from being compliant. Okay, those are also relative. Then conditions that increase the risk of perioperative complications or limit tolerance of immunosuppression. For example, peripheral vascular disease and all that is not amenable to revascularization. Then finally, frailty. Frailty is also a relative contraindication. So before heart transplant, you want to assess the patient by a multidisciplinary team made up of the cardiologist, the pulmonologist, the cardiac surgeon, the rehabilitation person, everybody that is needed, physiotherapist and all that. So everybody, the transplant team is usually a multidisciplinary team. So you want to screen, there should be careful patient screening, careful patient selection. You want to educate the patient about the risks and the benefits, okay, the importance of the procedure, how risky it is, the chance of dying, other options that are possible. Okay, you want to indicate, because sometimes in patients who have in countries that have central donor systems, okay, you want to tell the patient that it is not actually in your hands when a heart will come. That you just put the name on the transplant registry and you wait. Okay, so all those things the patient should be told upfront. Okay, and while we are waiting, this is what we are going to be doing. This is how we are going to be managing you and all that. Then there has to be thorough workup by both cardiology and pulmonology to optimize cardiac and pulmonary function before surgery. And that thing is to consider bridging therapy. Okay, so you should consider, can we use an assist device as a bridge to transplantation? What else can we do? Okay, so you should consider it too. Then bridging therapy, include like an assist device or ECMO. Okay, sometimes it could start as a bridge but end up as a destination. Okay, so it could be a bridge to candidacy. Bridge to candidacy simply means that it's a bridge until you find the heart. Okay, to be a bridge to decision. Okay, short-term mechanical circulatory support while awaiting LVAD. So it could be a bridge until you decide what actually you want to do. And it could also be a destination therapy. This is not my focus, so I'll leave it. So other things you want to do is to assess the prognosis and the fitness for the person. So you need to get the height, the weight, the BMI. You need your blood test, thyroid function, iron studies, glycated hemoglobin, BMP, bone profile, lipid profile, urinalysis, tox screen, albumin creatinine ratio, culture. You need to assess you need to do virology, hepatitis B, C, HIV, Epstein-Barr, cytomegalovirus, varicella zoster, toxoplasma, MRSA. Okay, you need to check the blood group because ABO incompatibility is actually a contraindication. Then tissue typing. Okay, then imaging, patient should go through an echo, both the donor and the recipient actually, routine echo, chest x-ray, CT, angiography, cardiac MRI, all those things are done pre-transplant. Okay, then you also need, if the patient has a pacemaker or an ICD, to interrogate it. Then a 6-minute walk test, that's the cardiopulmonary exercise testing that we talked about. Okay. If the peak oxygen exchange is less than 10, is a strong predictor of poor prognosis. You need to do a lung function test, to do a right heart cath, get the right HR pressure, get the wedge pressure, get the cardiac outputs. Cancer screening, okay, PSA, colon cancer, cervical cancer, whatever it is that is common, age appropriate in the individual. Dental review, then review the patient's vaccination. Okay, now for most patients, for most countries, of course, we don't do cardiac transplants here in Nigeria. I'm not sure if it's done in Ghana, but for developed countries where it's done, the organ allocation is usually handled centrally in most countries, okay? And this allocation is based on the urgency of the clinical situation, how bad the patient is, how long has the patient spent on the waiting list, how far is the donor from the recipient, because the donor heart should be in transit for more than 4 hours. Okay, so you give it to somebody who is close by, not somebody who it will take 6 hours to get to. Then blood group, ABO blood group compatibility. Okay, what do you need for a cardiac transplant? You need a donor heart, very important. The heart has to be well preserved. Okay, then you need an eligible recipient. You need to be able to bypass. You need to have a cardiopulmonary bypass. You need a bypass machine. You need a theater equipped with a bypass machine. Of course, you need a well-equipped theater with all the necessary instruments. Okay. So how the donor heart must have succumbed to brain death from some other catastrophic events, road traffic accidents, whatever, and must be free of any cardiac pathology. Okay, so if the person has, maybe if it's a RT and the person has some cardiac contusion, okay, it precludes donation. Donors who are cocaine, strongly use cocaine also precludes donation. So echo remains the best screening test for donor hearts. So what you see on echo that qualifies the donor heart, if they have a normal ejection fraction, they have a normal valve function, no stenosis or regurgitation. Then if they have absence of left ventricular hypertrophy. Excuse me. So all these are indicators of an excellent heart for transplantation. However, some minimal abnormalities like mild MR, mild TR, mild LVH, depending on the situation, these things are judged on a case-by-case basis, maybe said. Okay, then other donor criteria include age less than, you don't want an elderly donor. They are usually associated with poorer prognosis. Then the donor must not have coronary artery disease. So once these criteria are met, matching is done according to ABO compatibility. Okay, the first thing is to get to the procedure itself. I tried to understand this. I will do my best, but some parts were not clear to me, but I will do my best actually. So the first thing is to confirm the suitable donor and coordinate with the transplant registry. Of course, you must get a written consent. Everything must be in the theater. Then, of course, you take out the recipient's heart first. Then you put the patient on bypass. Like I said, there are two types, orthotopic and heterotopic. Okay, orthotopic has two methods. There is the bicaval method, and there's a Shumway lower method. Okay, but whatever the method, if there's a PFO, the PFO is closed. That's in the donor heart now. PFO is closed. Then some usually do tricuspid valve annuloplasty, especially for the Shumway lower method, because he said that tricuspid regurgitation is high post-operation. So they do annuloplasty to help prevent or reduce tricuspid regurgitation. So the ventricles are excised, leaving the great vessels, right atrium and the left atrium. This is actually for the Shumway lower method. But the bicaval method said to be more common. It's said to be more common. So what they do is to connect the donor and the recipient's SVCs, IVCs, as well as the aortic and the pulmonary great vessels. The left atrium retains its roof, including the pulmonary veins. The donor left atrium is then sutured to the retained atrial tissue. This technique is important because it maintains the function of the right atrium, of the donor right atrium, unlike in the other one, where the recipient actually keeps his right atrium. And this is important for early postoperative right heart output and helps in preventing atrial arrhythmias, which are less common in this bicaval method. Okay, so after that, the recipient is left with a surgical denervation. Okay, therefore, it's not responsive to any either physiologic, sympathetic, or parasympathetic stimuli. Okay, so they said even if they're having bradycardia, you can't usually use atropine because it won't work. Okay, so they now use high-dose catecholamines to maintain adequate function. This is a picture showing, this is the recipient, a picture showing when the recipient's heart has been excised. Okay, this is the bicaval method, and this is showing when the technique has been completed. Okay, you can see the suture lines here. Then this other method is the Shumway method. A median stenotomy is done. Okay, then cardioplegia is used to help keep the heart and reduce ischemic time, because the patient is put on bypass, the recipient's heart is removed, the donor heart is inserted into its place, and the left atrial anastomosis is performed, followed by the right atrium and the great vessels. So this is, let me go back. Okay, so this is how the individual looks. This is the recipient. Okay, this is the right atrium. What is left of it? This is the left atrium. So the others are now the remaining parts of the donor right atrium are sutured here. Then the remaining parts of the left are sutured here. Then the ventricles will also be attached here. This happens while the patient is on cardiopulmonary bypass. Okay, so this is the donor heart, how it looks. This is where will be sutured to the other place. This is the transplanted heart after everything has been sutured. So these are the suture lines on the transplanted heart. Okay, now they rarely perform heterotopic transplantation. So this is just, you are transplanting the donor heart with the recipient's heart inside. So you're not removing it. So there's an anastomosis that is made between the donor and the recipient's atria. And the donor aorta is anastomosed to the recipient's aorta. The donor's pulmonary artery is anastomosed to the recipient's pulmonary artery. Okay, so it's particularly useful in patients with severe pulmonary hypertension. Okay, it's not usually done because of its problems, which include pulmonary compression. It's more difficult to obtain a biopsy, okay, to look for cardiac allograft vasculopathy in patients who have heterotopic transplantation. Then there's also need for anticoagulation. So this is just a picture of heterotopic transplantation. This is the recipient's heart inside too. Then this is the donor heart as it has been sutured, and you can see all the suture lines. So excuse me. Okay, so post-op, you want to monitor vital signs, monitor the electrolytes daily. Patients will stay in the hospital for up to 3 weeks. Monitor for hyperglycemia, which is a common complication post-op. Monitor for AV block. 10% will have AV block. It's treated with epicardial pacing. You aim for a heart rate of up to 90 beats per minute. Okay, if it persists more than 3 weeks, or the patient has symptomatic bradycardia, you may want to consider permanent pacing. Okay, then most times they are on a combination. Once they come out of theater, they're on a combination of, in fact, for most cardiac surgery, actually, especially those that didn't go so well, they're usually on a combination of multiple inotropes, adrenaline, isoproterenol, milrinone. Okay, then you want to treat any tachyarrhythmias that may develop in the initial time. If it persists, you may want to ablate. You want to watch for wound infection. Cardiothoracic surgeon will have to remove the drain, their usual practice. Then the patients will be on surveillance endomyocardial biopsy to look for evidence of rejection. Okay, rejection is usually 10 to 12% in the first year. So post-transplant care is usually multidisciplinary. The aim is you want to prevent and manage complications. You still want to look out for surveillance, actually, for complications. Then patients must commence, you want the patient to commence physiotherapy and cardiac rehabilitation. Other things that are important is vaccination. Although live vaccines are contraindicated, but you want to vaccinate against influenza and pneumococcal infections. You also give routine prophylaxis for CMV, Candida, HSV, and Pneumocystis jirovecii. These organisms are important causes of infection post-transplant, especially as they will be on immunosuppression. So they are prone to a lot of opportunistic infections. You want to do regular echo on the patients, watching out for the ejection fraction and general, then also watch out for tricuspid regurgitation and all that. Then statins, patients must be placed on statins and rapamycin. Rapamycin, that's the, I'll still talk about it later, the mTOR inhibitors. They have been noted to delay the onset of cardiac allograft vasculopathy, which is one of the commonest complications that they may have. Then therapeutic drug monitoring. Most patients will be able to return to work after 3 to 6 months. Okay, then they will also need cardiac rehabilitation. Now, post-transplant, one thing they must be on is they must be on immunosuppression. Immunosuppression is commenced at the time of transplant, and immunosuppression is for life. They must be told that immunosuppression is for life. Just that the agents may change, but they will always be on immunosuppression. Okay, now because of there are 2 phases, there's induction and maintenance. Okay, because the immune reactivity and graft rejection are highest early within the first 3 to 6 months. Okay, and they decrease with time. So therefore, immunosuppressants are usually started at a higher dose early and also tapered and reduced with time. Okay, another principle of immunosuppression that is better to use many drugs with non-overlapping toxicities rather than using a high dose of 1 or 2 drugs. So you see them using up to 3 to 4 drugs that have different side effects rather than using only 1 drug at a very high dose to produce the immunosuppression that is required. Okay, then it's also important to avoid over immunosuppression. Of course, it will predispose the person to infection, opportunistic infection, and even malignancy. Okay, so let's talk about, so I said there's induction therapy and maintenance therapy. Induction therapy, the things used can be either the monoclonal antibodies or the polyclonal. Okay, monoclonal include basilizumab, it's a CD25, selectively binds to interleukin-2 receptor, and it blocks the binding of interleukin-2 to its receptor complex. So this will now inhibit interleukin-2 mediated T lymphocyte proliferation. So that's how it causes its own immune suppression. The other example is alemtuzumab, basilizumab and alemtuzumab. They are both monoclonal antibodies for induction. Okay, then polyclonal is anti-thymocyte globulin. That's the preparation used. Okay, so they contain antibodies which are directed against a wide variety of human T-cell antigens. Okay, and they cause rapid depletion of T lymphocytes by inducing complement-mediated cytolysis and cell-mediated opsonization in the spleen and the liver. So that's how they cause immunosuppression. Maintenance therapy, the things used for maintenance are the calcineurin inhibitors, the antimetabolites, and the corticosteroids. Okay, so the calcineurin inhibitors are two, tacrolimus and cyclosporin. So they inhibit the molecule calcineurin, which is responsible for the transcription of interleukin-2, tumor necrosis factor alpha, granulocyte monocyte colony stimulating factor, and interferon gamma. So all this will lead to blunting of T lymphocyte activation and proliferation. Their major side effects include, I know they ask us this a lot, they can cause a reduction in kidney function, hypertension, dyslipidemia, hypokalemia, hypomagnesemia, and neurotoxicity. These are common for both, these side effects are seen in both cyclosporin and tacrolimus, but gingival hyperplasia and hirsutism are two additional side effects that are usually unique to cyclosporin, and these are very concerning, especially in young females or young individuals. Then another thing to note is that tacrolimus is associated with less dyslipidemia and hypertension. However, it has been known to be associated with new onset diabetes. Tacrolimus is generally milder. That's why it's now being preferred when it comes to side effects. Okay. Then the other drug for maintenance is the antimetabolites, and they include azathioprine, mycophenolate mofetil, MMF, and mycophenolic acid. Azathioprine is, like we all know, it has many uses in medicine. It's a prodrug which is converted to 6-mercaptopurine and is subsequently converted to the purine analog thioinosine phosphate. It works by incorporating into the DNA and inhibits further nucleotide synthesis. It's antimitotic, thereby preventing proliferation of rapidly dividing cells, such as activated T and B lymphocytes. The major side effects include myelosuppression, especially leukopenia. They said that you withhold azathioprine if the white blood cell count is less than 3,000, or if there's more than 50% drop in the previous WBC count. Other side effects include hepatotoxicity and pancreatitis. Although nowadays MMF is now preferred to azathioprine, MMF is rapidly hydrolyzed to mycophenolic acid, MPA, okay, which is a reversible inhibitor of inosine monophosphate dehydrogenase, which is a critical enzyme for de novo synthesis of guanine, that's the purine nucleotide. It's not nephrotoxic, and it causes less bone marrow suppression. That's why it's now being preferred. But however, it can cause dose-related leukopenia and GI toxicity, so as nausea, gastritis. It has also been said to be associated with polymorphonuclear leukoencephalopathy. It's important for us to note that MMF is contraindicated in pregnancy, okay, due to the risk of miscarriage and teratogenicity. So women of childbearing potential, in fact, they say that women should stop MMF 6 weeks before they conceive. Okay, then also men who are intending to have children should not be on MMF because of the risk of teratogenicity. So it's not just in the women, but also in the men. Okay, steroids are also used. Steroids are started from when the patient is off bypass. Okay, then the typical one is methylprednisolone, which is given an initial dose of 500 milligram, followed by 125 milligram every 8 hours. Subsequently, the patient is placed on oral prednisolone, 1 milligram per kg in 2 divided doses. So you start weaning off the steroids by 3 months. It's possible actually to keep the patient off steroids after 6 months to 1 year, depending on how the patient is doing, because of the numerous side effects of steroids, which we are all familiar with. So 80% of patients will be on just tacrolimus and MMF at 1 year post-transplant. Then of recent, there is the mammalian target of rapamycin inhibitors. That's sirolimus and everolimus. So they inhibit a protein kinase in the cytoplasm called mTOR. Okay, the side effects include hyperlipidemia, oral ulcers, edema, bone marrow suppression, thrombocytopenia, anemia, poor healing complications, pleural effusion, pericardial effusions. Okay, then pulmonary toxicity has also been reported with sirolimus. Everolimus has the same side effects, but is noted to be milder than sirolimus. What are the complications of cardiac transplantation? They are divided into early and late. Early happens within days and late within months to years. Early include primary graft dysfunction, so failure of the graft to function within 24 hours. That's hyperacute rejection. Okay, there are many causes. It could be due to hyperacute rejection. It could be due to pulmonary hypertension or bleeding. Okay, then there's also rejection. There's also rejection if there's an interaction between the recipient's immune system and the allograft. It could be cell-mediated or antibody-mediated. Rejection could be mild, moderate, or severe. Okay, other early complications includes infection. Infection puts the patient at great risk of death and is greatest in the first year due to maximum immunosuppression. Other delayed complications include cardiac allograft vasculopathy. This is just coronary artery disease. Let me put it down. That's where I understood it in the transplanted heart. Okay, the drugs, both the drugs and the procedure also puts the patient at risk of cardiac allograft vasculopathy. It's characterized by narrowing or occlusion of the coronaries in the allograft and it's usually diffuse. They usually do not benefit from revascularization. Okay, that's why they consider retransplantation. The risk factors for it is immune-mediated. If there is HLA mismatch, then non-immune mediated age, that's high age. If the patient, the recipient had background coronary artery disease or had other risk factors for coronary artery disease, such as smoking, hypertension, dyslipidemia, and obesity. They usually present with angina and heart failure symptoms, shortness of breath, autopnea, PND, and all that. It's a delayed complication of transplants. Other delayed complications include new onset solid malignancy. The 10% increase in malignancy after 1 to 5 years of transplant. Then others include complications related to immunosuppression, such as malignancy. Some of the drugs are related to malignancy, Epstein-Barr-related lymphoproliferative disease, and all that. I've talked about the side effects. Those are also, all those things will also come here. Let's talk about pregnancy post-transplant. In the first year of transplant, it's important to discourage the individual from getting pregnant. And when they are now ready to get pregnant, there must be preconception counseling, thorough planning. Patient must be managed by a multidisciplinary team, gynecologist, cardiologist, cardiac surgeon, respiratory physician, and all that, respiratory therapist, and all that, physiotherapist, and everybody. Okay. Calcineurin inhibitors and steroids are stable and they can be continued throughout pregnancy, but you must stop MMF 6 weeks. And I've talked about males stopping MMF before they give birth, before they intend to start children. 1 year survival is approximately 90% in North America and 80% in Europe and other parts of the world. Median survival is greater than 12 years. Then prognosis also depends. There are some factors that favor better prognosis, some favor poor prognosis. So these are some of the things, the recipient factors that contribute to poorer prognosis. If the patient needed ECMO, mechanical ventilation, assist device, if the patient has had prior cardiac surgery for whatever reason, they also have worse prognosis. Generally, dilated cardiomyopathy or non-ischemic cardiomyopathy has the best prognosis for transplanted patients. Okay, has a better prognosis than congenital heart disease, hypertrophic cardiomyopathy, valve disease, even ischemia, or even restrictive cardiomyopathy. Okay, then patients who are very young or very old have poorer prognosis. Patients who have reduced EGFR, high levels of bilirubin, elevated pulmonary vascular resistance, Patients who have multiple circulating antibodies, of course, they will have an increased chance of rejection. The patients who were severely ill prior to transplantation. Then if their donor antibodies appearing in the first year post-heart transplant is also an indication for poor prognosis. Then in the donor, the older the donor is, the poorer the prognosis. If the donor has LV dysfunction, okay, ideally you should not transplant somebody with an EF less than, should not use a heart with an EF less than 50% as a donor. So the lower, the more the dysfunction, the worse the prognosis. Then also it's noted that these things are actually from studies. They're actually gotten from the International Society for Heart and Lung Transplantation after they have followed up patients over years. So that's where this was gotten from. They also noted that a female to male or a male to female has also worse prognosis. Okay, then if there is a donor to recipient size mismatch, so if you are giving a donor heart into a relatively larger recipient, it's also known to negatively affect survival. In conclusion, cardiac transplantation is the treatment of choice, like I've said, for many patients with end-stage heart failure who remain symptomatic despite optimal medical therapy. Careful patient selection is important in ensuring optimal outcome. These are my references, and thank you. Thank you very much for your time.
Yes, thank you very, very much, Dr. Corey, for a very comprehensive overview of cardiac transplant. Yeah, it's you know, for us practicing this part of the world, it's as if we are watching a science fiction movie. Yeah, but other places where facilities are available, these things are happening in reality. Yeah. I think I'll open the floor for questions and comments. I don't see anything in the chat. Something just keep fascinating me about the ethical aspect, you know, of for the person donating, because from what you explain, it's someone who is brain dead, okay, and then they take the person to theater and harvest the heart. So what do they do at that point? Do they pronounce the person dead before they take to theater, or they just take to theater and harvest the heart, and then after which pronounce the person dead? I'm just thinking around those ethical issues. What do they actually do? I don't know if you have answer to that, but just, you know, I think those things are just running in my head. And the other thing that is puzzling me, the heterotopic transplant. I mean, thinking first of all, that mediastinum was made to accommodate one heart. Now you have two hearts in there. Even the normal functioning of the transplanted heart might be compromised, because anything outside the heart restricting the heart can produce a tamponade-like effect, you know, restricting function of the heart. And then you have two hearts functioning. How are you going to synchronize their contraction to make sure that like one is not antagonizing the other? Not to thinking about doing echo assessment post-transplant of such patient with two hearts in the chamber. I wonder what you'll be seeing when you put your probe on those kind of patients. It's just a lot of things going through my head.
Well, truth is, in that heterotopic, I think they actually connect the original recipient's heart is not functioning, is not connected. So they have connected the all the blood is now passing through the donor heart. I think that's the summary of it. But I actually I don't have an answer to what you see on echo and all that. But they said it's not usually done.
Yeah, okay.
So, and the only time they want to do it, because it has a poor effect on lung function. The only time they want to do it is when you have severe pulmonary hypertension. Actually, I don't know why, actually. Then I think I'm trying to remember your first question. Sorry, just keep
it was about when are they pronouncing the person dead? the one that is donating the heart?
Yes. This is actually because there are a lot of ethical issues associated with cardiac transplantation, because you'll be thinking, who actually gives the consent? This patient is not able to give consent. Who gives the consent? Although some people sign like advance directive, when I die, you can do this and do that. But for those that didn't do that, I don't know whether a family member is able to give the consent. There are a lot of, even in the advanced countries, but I think most countries will have country-to-country guideline on how to go about the procedure, and whether it's the wife or the closest relative or somebody like that gives consent for such procedure, because it's usually done fast. It's easier in a patient who may have been ill for a while, maybe ill from some other thing, and the heart is still fine. But if it's like a sudden death, maybe road traffic accident, that kind of thing, I don't know. It's actually maybe somebody, others can throw more light on it.
Okay, thank you very much. Thank you. Any other questions from our colleagues? Just on a lighter note, I'm seeing several ways of saying thank you. I'm seeing the Ghanaian way, Midasi. These are the ones in between. Can you help me? What are those? That is what I've heard that in Nigeria movie. So what language is that?
Eshe is Yoruba.
Yoruba.
Dalu is
Okay.
Igbo. The Nagode is Hausa.
Hausa. Okay.
Medasi is a tree.
It's true, yeah. Midasi. Pa. Okay. Any further questions?
Okay, I do have. Okay, so
Yes,
Dr. Charles Okere, please just add Imiete. That's thank you from my own language. Thank you, Imiete, for a wonderful presentation.
You have to spell it for me.
IMI. Also IMIETE. Yeah, Imiete. Thank you. Imiete, for a wonderful presentation. Okay, so my question is still in relation to Dr. Conte's, what Dr. Conte brought up. I just want to know, while he was speaking, you actually heard when you said that they do this heterotrophic heart transplantation when the patient has pulmonary hypertension. I don't know if I heard right. So I want to know, what are the indications for the heterotrophic heart transplantation and that of the autotrophic? Like, what are the indications? In what conditions are we doing any of them? And why do we have to, think of heterotrophic when we know that it can actually compress the lungs and compress other organs in intrathoracic? I don't know if you get what I'm trying to say. So why do we have to go for heterotrophic? Is it that it's faster to do? Is it that it's easier to do as compared to autotrophic cardiac transplantation? I don't know if you got what I just said.
I get your question. Is the answer that? But I think the heterotrophic is actually rare. They hardly do it, from what I gathered. What most people would do is an autotrophic transplantation. I actually tried to, maybe I can search more to understand why they said that you want to do heterotrophic when there is severe pulmonary hypertension. I don't understand it actually, but that's what I saw, where I got most of my information from. That I want to do it when there is severe pulmonary hypertension, but it's rare to do it. Most do autotrophic, most do using the bicaval approach, okay, where they talk about incising the left and the right atrium and doing all the suturing and all the anastomosis. So that is, I'm not, maybe I'll look for more information to be able to answer the question.
Dr. Okori, probably it helped protect the donor heart from the effect of the pulmonary hypertension, because for the autotrophic transplant, severe pulmonary hypertension is a contraindication.
Yes, so that's true.
From that angle, I think when they leave the recipient heart there, it sort of continue to carry the load of the pulmonary pressure somehow. and protect the donor heart from the effect of the pulmonary hypertension. That's just my thought around it.
Yeah, that's very true.
Yes.
Yeah.
Yes, and it also helps to assist the patient's naive heart to maintain circulation in cases of severe acute rejection. That's another advantage of the heterotrophic heart transplant over the autotrophic heart transplant.
Sorry, Dr. Rapo, you said what? You said it reduces what? It reduces rejection.
Yeah, in cases of severe acute rejection. So the heterotrophic heart transplant is actually better because it helps to maintain the patient's naive heart. So let's say the patient, there's a severe acute rejection now. The recipient heart will help protect the heterotopic heart by reducing the severe acute rejection. I don't know if you got what I said. In the same way where Dr. Conte was talking about the pulmonary hypertension, severe pulmonary hypertension.
Okay, I'm trying to understand.
Okay, let me put it like this. It helps to assist the patient's naive heart and to maintain circulation in cases of severe acute rejection. Do you get it like that now?
I do, thank you.
All right.
Sorry, Dr. Irhapa, can you just repeat what you said?
Okay, let me put it like this again. Heterotropic heart transplant is a surgical procedure that allows the graft to be connected to the naive heart in a parallel fashion. The main advantage of it is to assist the patient's naive heart and to maintain circulation in the cases of severe acute rejection. And it's also good in simplicity and in close monitoring in tissues for an event in case of a malignancy in the graft. So that's why they want to leave the other one just in case all these problems arise.
Okay, I get it now. So it doesn't really prevent the problem, but in case it occurs,
No,
you
not
need to heart scan. Yeah. Okay.
Yeah.
Okay, thank you. Hello?
Dr. Conte. Okay.
I just have a question. Like, so during the procedure, which is done first? Is it that the donor heart is harvested? How do you really prevent the ischemic time as you're harvesting? Are you also taking the recipient to the theater? Like, just paint a picture of how this goes on. Thank you.
Okay. Thank you for your question. I think both are done simultaneously. I think both are done at the same time. But that issue of ischemic time, there's a solution I saw called cardioplegia that helps to, like, even cardioplegia is even used in anything that involves bypass, actually. It helps to reduce the ischemic time to ensure that the heart muscles, okay, are doing less work at that particular time. Okay, and one thing I noted about the cardioplegia solution is that it has high potassium content. Okay, so but both things are going on at the same time. If for advanced countries or maybe the way we see it, if a patient is a heart is coming in maybe 1 hour and 30 minutes, so they know how long it will take to get a median stenotomy, how long it will take to excise the heart, how long it will take to open the pericardium, how long it will take for it to get the patient on bypass. Okay, so you can now like judge, okay, from when the heart now comes and you now begin to transplant. So it's actually a most times is a multi-team coordination, even most times even a multi-center coordination, because it's not just one team. It's not like they did in the first heart transplantation. They first of all went into the opposite theater, started, then now brought the heart. But this time around, I think there is more coordination that happens. Thank you. I think that's the answer.
Okay, then
Yeah.
regarding the testing, all those CMV, the HLA typing, when do they do it? Like, let's say maybe the donor is maybe an RTA patient. So really, just
Well, I did not see where they are big on HLA typing for heart transplantation. I was actually looking out for it. They are not big. That's why they have a lot of immunosuppression, and they also have high chances of rejection. But they don't do HLA typing routinely for cardiac transplantation. The only thing that the patient must satisfy is ABO blood group compatibility.
okay.
Yeah, and just to contribute, I've seen a kidney transplant done. You know, I've witnessed empathic while doing the membership. So they do them in parallel theater. So you have a separate team that do the harvesting, okay, while the team that is also going to transplant the other organ is also working, you know, getting the recipient ready to do the transplant. And usually for the kidney transplant, there are actually two surgeons. So you have the transplant surgeon who does the connection of the kidney structure, mainly the pelvis of the kidney. And then is a vascular surgeon that connects the vessels. Okay, and then they now, after they finish, then they establish circulation and warm the kidney up, and then see that it is functioning before they close. So it's really a big team. So the team that harvests is usually separate from the team that reattach the organ, and the theaters are parallel. So they harvest, they bring it over, and then the ones who are in transplanting continue their procedure.
Dr. Conte, can I go ahead? In case you're done?
Yeah, I think you can. I don't think
right.
another question from the participants. Yeah.
Okay, so that we can round up fast and call
Sorry,
on.
Chief, before you make comment, Chief.
All right.
Okay, Ayodeji, you can go ahead. You can go ahead. Okay.
And just to make mention that of course, different types of rejection, there are peracute, which is usually due to preform antibodies. And then you can have the acute, which can be cell-mediated or even immoral. And then you have the various gradings. So I think we should know before MCQ. And then those delay complications that happen from months to years of transplant. That is the CAV that you talked about. Then the malignancies, like the HPV-related malignancies, said to be the most common. You can also have the EBV-related lymphoproliferative cancers too. And then most arrhythmias too that they can have as a way of complications. Hello?
All right, are you done?
Yes.
Thank you so
Thank
much.
you. Thank you.
Thank you. Yeah.
Thank you so much, Dr. Oyed, for that contribution. Thank you, Dr. Charles, for giving us a very warm presentation on heart transplant. Let's, in the absence of other contribution, let me call on Dr. Allison to make some contribution, then I'll make some and ask a question, then we'll call up Prof. Dr. Allison, please, you have the floor.
Yes, thank you. Chief Okopi, thank you, Dr. Charles, for your detailed presentation. Well, I must appreciate you, because when you present something that you had hardly seen before, there's a way it resonates with me to have known that you've done a lot of hard work. So well done. Thank you so much. I stepped out during one of the presentations. I wouldn't know if you mentioned the complications that we can have if we, there are two types of implantation you can do. Yes, I heard you mention bicava. The one they were using before was the intraitral. What is it called? Bilateral anastomosis as against the bicava. So the bilateral was formerly used, and it's they stopped using it because of the complications that it comes with. So we now use the bicava. So the bicava does not really give all the arrhythmias that we see before. And there's also something about the denervation and how the denervation is treated. I'm not sure if you mentioned that. It comes in MCQ. So when we have bradycardia from heart transplants, we cannot use atropine. So you should take note of that. So isoproterenol is the drug of choice. Some people use dobutamine too, but at least for MCQ purposes, isoproterenol, that's the drug of choice for that. Then it's also good. Dr. Ayodeji was trying to mention it. There are some MCQs that we see that they will ask the one that is the duration, the acute, the chronic, and the duration. There is one particular one that you mentioned, that one that has to do with the vascular, I've forgotten the full name now, like CV, something.
CV, cardiac,
Cardiac
CADP,
allograft vasculopathy.
Yeah,
allograft, vasculopathy.
there was a question, Dr. Ayodeji, I'm not sure if you can remember what is coming to my head. Was it in our exam that has to do with the pathophysiology of that? There's a question on that in our exam, pathophysiology of that CV. How will I say it?
Yeah, I think it was in the MCQ and the treatment of choice.
Yes, it was in the MCQ and the treatment of choice. The time it happens, the pathophysiology and the treatment of choice. So I would like to say that I don't know. Please, let's go and read Harrison. It's not much in Harrison. That's cardiac transplants in Harrison. The complications, the three, just like Dr. Ayodeji. But I don't know the book you are reading from, Shao. Maybe that one is simpler. But I remember I read Harrison for cardiac transplant in exam, and I was able to answer the exam questions. So the pathophysiology of those rejections, the drug of choice, and the timing. There are three of them. There is one that is sorry, I can't remember. There is acute cellular rejection. There is antibody-mediated rejection. And there is the vasculopathy that we talked about. So the three, the mechanism of action, the timing, and the drug of choice is quite important. At least it came out in our own MCQ, although we didn't recall it. As we were presenting it, I remembered. Then another thing I would like you to check is the complications. We know skin cancer is the commonest complication. So we should know all those complications of treatments with their frequency of occurrence. So there was a question we saw then, maybe we answered in MCQ. We don't know if they can repeat it. The commonest complication, the least complication, and it can even come out as OSCE, part of oral questions. So that's at cardiac transplants, really. So you should please take note of that. Then the issue on the timing of surgery, someone asked, I think Dr. Sambo asked about history of the timing and how it's done. And I know Dr. Conte tried to answer that. We should know that I don't know, it's just somewhere in my brain now. There is a way that when someone that is an organ donor is dying or wants to die, the person those that are on the transplant list, they notify them. They will tell them that they should not travel to any distance. There's a way they tell them that they should be at arm's length. They shouldn't travel. They must not miss their medication. They put them on. There's something about management of patients say recipients, yes, cardiac transplant recipients. That there's something about how we manage them. We should also check that up. They must be on guideline-directed medical therapy, the frequency of visits to make sure that, yes, we know you are the next online. You have to be, you understand, you have to be compliant to medication adjustment so that at any time that the heart is ready, they are ready to receive it too. So they tell like 1, 2, 3 of them that are around, you understand, as they queue up. So they tell them what to do, how frequently they see them in the hospital, especially for those who are on assisted devices but are outside the hospital, they are not on admission. So that's 2. Then there's something about how they transplant. If there's something about the distance. So if you are to receive from so person now, we are matched. The other person has said that yes, you can give my organ. And maybe at the time where the organ donor is, might not be within the states. Maybe has an accident or something, and they know that there's no how they will be able to transport to the next person online. So someone mentioned, which is quite right, they contact like a teamwork, and it will be, they contact people in different, we call them like a pool. They interlink. You understand? So whoever is closest to receive the organ will be the one they will give, even if you are not the next person online. So all those things too we should know. Then the way they transport, there's something about tissue time to prevent ischemia and all those things. I've forgotten the how to quote. I can't quote correctly now, but there is tissue time, and there is the fluid or the solution, yes, that Dr. Okore mentioned that they put into is very, very important, and the constituents of I've seen it in some MCQs before of the fluid. You should please know. You have said potassium and the like, so it's quite important. And you know that when they might say in MCQ too that when they harvest when you want to harvest on like maybe the kidney now, even if the person is brain dead, you have to harvest the heart while the heart is still pumping. The moment there's something they call that if the heart is not pumping again, there's the ischemic time is that means it has been prolonged. And when you implant it into the donor, into the recipient, it increases the risk of either rejection or for it not to take. I don't know how to really explain that well, but what I shall know is the person is brain dead, you must be fast to harvest the heart, because the moment it stops pumping or stops contracting, it will affect the how it's going to take in the recipients. So I think that's about all. Okay, thank you. That's all I can remember for now. Thank you so much, Dr. Okuri, for the presentation. God bless you.
Sorry, Chief.
All right, thank you so much.
I just posted the mechanism of the hypertension caused by the tacrolimus and the cyclosporine of the group. There are just 3 mechanisms of the hypertension.
Thank you.
All right. Thank you so much, Dr. Allison, for that brilliant contribution. Before we call on Prof, let me just make a few statements, and then we'll call, I may ask him a question that is exam related. Just to also say about the advantage of heterotropic heart transplant. Permit me to use HHT. I think that's how they code it. in addition to what we've said, one of the key things it does, it offers flexibility for us to manage conditions like, as we said, complex conditions like pulmonary hypertension, and why the native heart is still functioning and you connect the transplanted heart. It also, during the procedure, it is less invasive. So with respect to heterotropic heart transplant, the less invasiveness reduces surgical trauma recovery time. It also has been seen to be very valuable in specific conditions such as sarcoidosis, giant cell myocarditis, chemotherapy-induced cardiomyopathy, such that it gives the native heart the time to recover while you're also trying to treat some of these treatable conditions that would have been the reason for the transplantation. And also it offers the opportunity to win the transplanted individual from cardiopulmonary bypass earlier and also reduces post-operative complication. It has also been seen to reduce risk of primary graft failure. So this few importance. And I also saw that it helps in improving the hemodynamics of even the transplanted heart, the cardiac output, and improving the quality of life. Before I ask the question, I just want to also say some things about the therapy so that it can be a little bit clearer. And then I think in our own set, the last 10 questions were transplant related. So it wasn't recalled because most persons didn't get there, but I think I started from behind too. So with respect to the therapy, of course, he said the immunosuppressive therapy is key outside the transplantation. And it is divided into the induction therapy, as he said, which will involve high-dose immunosuppression just immediately after the transplant, and then the maintenance therapy. There are also specific therapies you needed to maybe put them separately. You need to consider antibody-mediated rejection treatments, such as plasmapheresis, intravenous immunoglobulin, cellular rejection therapy, as you said, corticosteroids and cytolytic therapy, infectious prophylaxis against antiviral, antimicrobial, antifungal. And then you also need to also state your treatment, cardiac rehabilitation, which for those that have gone through heart transplant, they undergo some structured exercise and education program, as Alison said, to improve their cardiovascular health and overall fitness. And sometimes they carry out some surveillance biopsy to monitor rejection, graft dysfunction. And then continuous ECG, echocardiography, blood tests to monitor graft dysfunction and detect potential complication over time. And in addition to the therapy, you must encourage or counsel the patient on lifestyle modification, some dietary changes, stress management, smoking cessation, and also psychological support. And not to forget long-term follow-up, long-term regular follow-up. So if you can reorganize your treatment in that format, it may actually help. In our exam, Prof described a very long scenario, and he used that to ask 3 questions on timing with respect to heart transplantation and transportation. So perhaps I'll just try to give some of the timings. I think it may answer some of the questions because he asked 3 questions. He described, okay, somebody died. That's how his questions are. Somebody died and so was carried, put in this. So what is cross-clamp time? What is ischemic time? What is total ischemic time? And what is implantation time? What is bypass time? All those stuff. So some of the specific definition, if you can add them, something like cross-clamp time. That's like the duration the recipient heart is stopped during the surgery. And of course, you said something about ischemic time, the time the donor heart is without blood supply from the retrieval to transplantation. Cold ischemic time, the time the donor heart is preserved in a cold solution, typically around 4 degrees Celsius. And if you can just add to your slide warm ischemic time total ischemic time, bypass time, the perfusion time. There's even anastomosis time also. Some timings with respect to heart transplant. So I think post-transplant time, perfusion time, bypass time, anastomosis time. I don't know if I've mentioned donor heart retrieval time. So these are all timings with respect to heart transplantation and transportation, because he actually asked a question with respect to that. He mentioned 3 different timings in the last sets of questions he asked us during our time. I just want to ask you a question, Dr. Corey. If you can discuss, I think this is how his question usually will come. Can you discuss heart transplantation in summary during or heart transplantation in or before pregnancy? Just a brief. What would you say? Because if you want to ask you this kind of question in the exam, it might not be what's the indication. Remember when we're preparing for the exam, we're preparing like that, but then it was a surprise. So a pregnant woman needs heart transplantation. Discuss heart transplant in or before pregnancy. Can you attempt it? Thank you.
Thank you, Chief. Where this question does not come in exam, but I'll attempt it. The thing is, I think that pregnancy is already a high output state, okay, that is associated with increased metabolic demand. Okay, so I'll discuss it. I'll discuss heart transplantation in relationship to pregnancy using pre-pregnancy, intra-pregnancy, or during pregnancy and post-pregnancy. First of all, the patient who has had a heart transplant and intends to get pregnant is to be followed up by a multidisciplinary team made up of the cardiologist, the obstetrician, the pulmonologist, then the physiotherapist, and those involved in cardiac rehabilitation, respiratory physician, or the respiratory therapist. Okay, and all these people will be involved. Then she should know that if she's on some drugs which may be teratogenic to the baby, like if she's on MMF, those drugs will be stopped before 6 weeks before conception. Conception must be pre-planned, and conception must be pre-planned, okay, and not accidental. Then also, a patient who is pregnant, if she's actually pregnant, okay, it will be actually extremely difficult, although I didn't see pregnancy as one of the relative or absolute contraindications, but it will be extremely difficult if a patient who is already pregnant needs a heart transplant. So if she's already pregnant and needs a heart transplant, my advice would be to be on some form of temporary support until she's able to be delivered of the baby, okay, using the fastest available means. So once the baby gets to the age of viability, she's delivered of the baby, and she can now be put on heart transplant. So in that period, she will be on other treatments for advanced heart failure, okay, such as the assist devices or other things that can assist the LV, ECMO or impeller, to pump and to function better. Okay, then post-pregnancy, a patient who has had a cardiac transplant is not expected to take in for 1 year. So pregnancy should be planned. She's not expected to take in for 1 year. I don't know. I don't have any other thing to say. I think I can stop here. Maybe welcome more contributions. Thank you.
All right. That's a brilliant attempt. From the psychology of our prof, if you see such a question, just the way you said, you have to structure your conversation along the lines you actually said earlier. Pre-pregnancy counseling. In your presentation, you actually stated almost everything, but just to help you organize your thoughts. So you talk about pre-pregnancy counseling, where the where women of childbearing age should receive counseling on the risk and challenges of heart transplant and pregnancy. And of course, you have to discuss with respect to the timing before transplantation can be done, either during or before pregnancy to minimize risk. And also, you need to also discuss with the patient fetal risk that will be involved if should there be on transplant medications. And then during pregnancy, you have to discuss case-by-case evaluation of respect to the woman involved, the teams involved. Just the pediatrician and gynecologist should be involved. And close monitoring during pregnancy should be there. And then also the delivery plan, when the patient should be delivered of the baby, it shouldn't and then postpartum care. And then actually what you said in your presentation, I'm just trying to put it to you the way he will bring question. It won't be directly like do this and list the indications or not. It's just the way I told you that the last 3 questions exams. And when you're reading it, you even know that it's asking you all the timings involved in transplantation and transportation. So please, if you can, on the slides, if you can add all those timings I mentioned so that we can have it in case it comes out again in the MCQ. We didn't recall it during our set. I think I forgot. But then 3 questions came out with respect to timing of transplantation and transportation of the heart. So thank you so much again for a warm presentation. Let me call on Prof to give contributions. Hello, Prof. Hello, Prof. Are you there? Oh, it seems we don't have Prof. Okay, all right.
I'm not sure I have any questions to ask. Yeah, it's really done well. But it's important to study all those clues they've given you, all those ischemic time. They are not hard actually. It's just for you to know what the timing means and the impact on it to the survival or outcome. We should know that the longer the ischemic time, the higher the risk of rejection or vasculopathy in the future. So, and those kind of conditions, they will not be amendable to immunosuppression or immunosuppressive therapy. So it's good to know those timing. The timing are very important. But one beautiful thing is that ischemic time for heart condition is still tolerable than for renal transplant. For renal transplant, everything is done on table as fast as possible. Unlike for heart transplant, they can still transport the heart, blah, blah, blah. But in renal transplant, for example, in heart transplant, you can harvest heart at Jos, at Jute, and transport it to UCH for donation. But in kidney transplant, you want to do everything inside the theater of Jute. You understand what I mean? So then don't forget the solution they ask about. There are many solutions, but the most common solution they use is developed by University of Wisconsin. So they usually call it UW solution, University of Wisconsin solution. So there are many modifications to that solution. So it's now depending on the electrolyte content that is actually in the solution. Both the glucose, the sodium, potassium, the quantity can be modified just to percenter, but the solution is universal. It's by University of Wisconsin, and it's a similar solution they also use for kidney, most of the transplants, even kidney transplant. Okay, the question asked about heterotropic transplantation. So interesting to me, I've only seen one autotropic, and I've seen like 3 heterotropic transplants. So I'm wondering why the presenter was saying that it's rarely done. Well, in my own scene, actually, well, I've seen.
In fact, it's mostly done, Prof. I wanted to even comment on this. It's mostly done than the autotropical.
I'm wondering why you said it's rarely done. So two
That's
patients
what I saw in the literature.
okay, I understand you. Well, in the patient managed in last year, the two patients I've seen is heterotrophic transplant they had. It's when I was training in India, I saw a young guy with autotrophic. I saw of them with autotrophic transplant. So, but well, maybe it's Nigerians they give heterotrophic, but I don't know what. I've seen heterotrophic a lot. So the question asked about, oh, will it compress the heart and all that? So it's important to know that heterotrophic transplant, the transplanted donor usually have a small normal size heart. So it's not going to give you a tamponade effect. Okay. And there still be spaces, the lungs is collapsible. So there's still spaces around the lungs or for the mediastinum to expand. So it's not as if they're giving a heart and you now have a tamponade and you now crush the whole heart. It's not like that. It's still functions. Next question that was asked about, so the indication for the heterotropic compared to autotropic, for the contraindication for autotropic is if the patient has developed pulmonary hypertension, then we both know we should do a heart and lung transplant. But for heterotropic transplant, you can still do it in pulmonary hypertension in the absence of right ventricular failure. So if the patient has not developed right ventricular failure, then heterotropic transplant can be done. But for autotropic transplant, when the patient develops pulmonary hypertension, either the right side failed or not, then transplant, just heart transplant alone is a contraindication. You need to do an heart and lung transplant. So the question about, I just want to remember those questions you asked. Someone asked about what will you see on echo? Will you see this and that? So you will see both. You will see about 8 chambers. You will see them and you see them connected. So one important thing you will notice that there will be cardiomegaly, right? But the same way you see core triathlon, that you see, to make it easier for you, just relate to how you see a core triathlon, either Sinesta or core triathlon dexter. It's the same way you see those atriums. Okay, you see them, they'll be nicely connected to each other. They will look like an appendage for the atriums and for the ventricles. So the main problem with this condition is that the native heart can retain thrombus because it's not effectively pumping like the donor heart. So because of that extra chamber that the native heart is not pumping, so they're usually on strong anticoagulants. The question, I want to be sure, is there any other one they asked you?
I think basically that's all. But Professor, before you came in, we took left heart catheterization. We don't know if you have any anything to say about it.
I'm sorry.
I remember the cases you took us to at Evercare Lekki, and we were able to recall the cocktail, that's verapamil, nitroglycerin, and heparin cocktail. And
yes,
a couple of advantages why radial access, femoral access, the modified Seldinger approach, the Seldinger, we spoke about it. And then someone was asking the advantages of is it puncture or something, the antegrade and the retrograde procedure with respect to assessing the left side of the heart. And then some other definitions like damping, ventricularization, and some other particular waveform dynamics that we need to know with respect to left heart catheterization.
Okay. Okay, so I guess so the first question regarding puncture sites for either radial or femoral. So well, radial is usually preferred more than femoral for technical reasons and is based on complications. So it's easier to control hemostasis in the radial compared to the femoral. We all know we've done a lot of dialysis, we've seen punctures even from femoral. It's usually difficult to, especially in obese patients, it's difficult to compress or maintain hemostasis in the femoral. Also, number two is that puncture from femoral, you can puncture high up above the femoral head. And by the time you are creating securing the hemostasis manually, you would think you're actually securing the hemostasis. If you puncture above the femoral head, there's nothing you compress that will secure hemostasis because above the femoral head is already going to a retroperitoneal space. So if you say you're compressing, there's nothing you're really compressing because it's going to be leaking into the retroperitoneal space. So retroperitoneal bleeding is higher in patients that have femoral puncture, especially when you puncture above the femoral head of the femur. If you puncture below the head of the femur, what will happen is that you're likely to have punctured the superficial femoral artery instead of the common femoral artery. Because of that bifurcation, common femoral artery will divide into superficial and profundus. So you likely puncture that. And by the time you are compressing, you'll be compressing over the abductor muscles, the muscles of the thigh. And it's not going to give you sufficient backbone for compression when you're securing hemostasis. So most of the time, patient will develop aneurysm of the superficial femoral artery. So you can see that locating the specific area to puncture femoral artery is technical, except you do it under fluoroscopy. So eye puncture above the femoral head will lead to retroperitoneal bleeding. Puncturing below the femoral head will lead to aneurysm or even AV fistula of the superficial femoral artery. So that is why if you do a radial access, bleeding complication is lower compared to femoral approach. Now, the disadvantage of radial approach is that the radial artery may be too small. They have spasm. They can have spasm easily. And so it makes it difficult to maneuver your catheters. They can develop occlusion of the femoral radial artery, which can lead to some ischemia of the digits. And so that is why we give some medication, which is the cocktail we talk about. So either you give combination of calcium channel blocker with nitrates, then heparin. So you give that so that it's basically for vasodilatation. So any of the calcium channel blocker, any of the two, which is the non-dihydropyridine calcium channel blocker, which is either diltiazem or verapamil IV. Then the IV nitroglycerin, then anticoagulants, which is heparin. So that is the cocktail, basically for vasodilatation, so that the artery are not going to spasm. And you can also, depending on the duration of the procedure, it can be repeated just to maintain that vascular access. So the approach, either you're going to the radial artery, you're going through the femoral artery, is still a retrograde approach to enter the coronary artery. There's no way you would enter the coronary artery coming from the ventricles, which is an antegrade approach. There's no way you enter the coronary artery that way. That means you have punctured the ventricle, come out of the aortic valve, and enter the coronary artery. It's not going to be possible, as in that is fatal. So it's a retrograde approach to either you're coming from the radial route or from the femoral root for the coronary artery. But if you're going to enter descending aorta or arch of aorta, then it can be an antegrade approach if you're coming from the radial artery, or retrograde approach if you're coming from the femoral artery. Hope we get that.
No, sir, we didn't get it.
Which one is that?
Okay, because I initially thought going through the radial artery and the femoral artery is actually retrograde, while going through the femoral vein or the brachiocephalic vein is anterograde. So right now you were talking about if we are going into the descending aorta, it being anterograde as compared to what I know it for being retrograde when we access the arteries. So I don't know why it now has to be antegrade when I know that accessing the arteries are retrograde. Like that's where I have the confusion. Thank you, sir.
So good. Hope I'm audible. I want you to get I'm audible, right?
Yes, sir, you are.
Okay, so I want you to get very, very well. You see, the English of the trigger is very easy. Just understand very easy. We want to understand meaning of retrograde approach coming from the opposite direction of blood flow, right?
Yes, sir.
Okay, good. So let's ask ourselves, if you want to access, let's say a patient has type B dissection, stand for type B dissection. So that would be the descending aorta, right?
Yes, sir.
So how would the blood flow reach descending aorta? It should come from ascending aorta, right?
Yes, sir.
Aorta and get to descending aorta, right?
Yes, sir.
So meaning that if I come from the radial artery and I'm going to descending aorta, will I go against the blood flow direction from the ascending aorta?
No.
Okay. So you now understand why I said assessing that if you are assessing coronary artery, every of your approach will be retrograde. It's different from assessing the descending aorta.
Okay, sir.
English is not
Okay,
hard.
I understand now. Thank you.
Yeah. Good. Okay. Yeah. Any more questions in that direction? And Dr. Kopi, you wanted to ask a question?
No, I just wanted to say that I understood what you were saying, but since she said she didn't, and you have clarified. Thank you, sir.
Okay. Okay.
Okay. I don't know if the other aspect can be the other aspect we spoke about. Okay, we spoke about if you think it's also necessary for us to know some hemodynamics with respect to left heart cath. Someone asked a question for damping, the hemodynamics with respect to damping, what it's all about. And then ventricularization and a couple of other specific clinical relevance with respect to left heart catheterization.
Okay. So I'll take for hemodynamics, I'm sure we all know this is well presented with slides, with pictures, but we all know the particular waveforms for each chambers. And it will help you a lot to know the location of which chamber you are in. Either even if you're under the fluoroscopy, the hemodynamics waveforms is very important. So it's important to know the waveforms for each chambers and each vessel. They have different waveforms, characteristic waveforms. So the moment you have a waveform of the ventricles, that's ventricularization. So meaning that you have a peak systolic, which will look like the systole of either the pulmonary artery or the systole of the aorta. And the diastole is almost zero. That means you are ventricularized. So you are seeing a systolic of 120 and you are seeing a diastole of around 0. That means you're in the ventricle, you're in the left ventricle. Or you are seeing a systole of 40, 50, and your diastole of 0, you're in the right ventricle. Okay? So that is ventricularization. It's classical on the waves. I think it should be one of the presentations, right? Hemodynamics in our lecture series. So,
Okay, we didn't put that in, but we don't know if you could, if we can take it along the lines.
yeah, I think it's important
That was,
for
okay.
the OSCE. Yeah.
Yes.
Remember, Professor, these days, he just comes with the waveform on OSCE and just puts it, and that's setting, gets in the OSCE station. He puts and identifying it.
Yes.
Okay,
So we don't know if we can. Sorry for pushing you too far. So I don't know because that particular aspect of the presentation would involve someone with hands-on experience in the cath lab. I know you took me to the cath lab, but those things have left my memory a long time ago. So we don't know if you can help us out in one of these days before the exams at your most convenient time.
Let me just ask, Chief, did I send part of it in those days as a slide?
No, sir. But we discussed it in the cath lab then, but we didn't do any slide presentation with respect to it. Yes, we didn't. We discussed it at Evercare in Lekki, but we didn't do a slide presentation. Even though we answered an MCQ question in Brown World that you came up to give some explanation. But with respect to Hokum, with respect to different aspects of the chambers and how to interpret it with disease condition, the clinical relevance, we didn't do as a presentation.
Okay. Dr. Conte. Okay. All right, no problem.
Yes,
What
Prof.
I'll do is,
yes, Prof.
I thought Dr. Conte was part of people that answered when we presented it. You answered some questions now. Remember that time?
Yes, Prof. Yes, Prof. But
I remember. I'll forget
So,
it.
or maybe I was not in the class, but Conte, did you do any presentation on that?
He answered question when we were presenting those waveforms. That's why I remember.
Okay. Okay, my bad then. I'm sorry, but I was thinking probably we had an official presentation on hemodynamics of left-heart cath.
Yeah, I will send it. I think I have it. I've checked through my laptop. I'll send it again now. We can now present it. But let me presenting is not hard. It's just making that slide that is the cuckoo. But thank God I've seen the slide. I'll just put it on the group now so that any day we are presenting. Okay. So I think that's answered many questions. So I'll just send you. Okay. I'm already sending through my phone to the group.
Okay, sir.
Any question I've not answered yet? Okay, damping. Yeah, to be present when we're presenting it, I will answer it more, but it's best to understand damping. Simply means that your catheter or what, it's either you're using swan catheter or regular catheters to check your pressure is actually two things can happen to it. It can get clogged with blood or air bolus. So it would, when there's no smooth flow through the catheter, either because of blood clot or air embolism, it would affect your pressure wave. It just reduces, all the pressure wave just crashes down. So that is damping of the catheter, okay? And that's why it's required that you do regular flushing, with a pyronite saline, make sure there's no air bubbles. Even if your tubings that connect to the invasive blood pressure is clogged with either clots, blood, or air bubbles, the same thing will happen. So that system chamber from the invasive blood pressure transducer to the tip of the catheter, that means the tip of the catheter that's accessing that chamber or that vessel, it must be free of what? Clots, and anything that can block it. Number two, another thing about damping is that if you enter a vessel that is narrow, so let's say the left main coronary artery is severely stenosed and you pass your catheter into it, you know, you will entirely block blood flow through that coronary artery. So that means that the pressure would dampen. So there are two important information from a damped pressure. One is that it's either there's something obstructing flow, which could be blood clots or air bubbles, or the catheter is in a vessel that is severely narrow and the catheter is obstructing blood flow to that vessel because of the narrowing of that vessel. They would all present with a damped pressure. And that thing that can cause damping is that if your catheter is on the wall of a vessel or the wall of the chamber, you enter the ventricle, let's say you enter the right ventricle and is eating, and the catheter is just directly opposed into the wall of the myocardium, you won't get any pressure. The same thing if it's directly hitting the wall of the, either the aorta or pulmonary artery, anything that is hitting the wall, it won't be able to transmit pressure. So those are things that will cause dampened pressure waves. So where you're expecting a blood pressure, a systolic pressure of 160/70 in the aorta, and you're seeing 20/10, that's a dampened blood pressure. So that tells you that something's happening to that catheter. Hope we understand.
Yes,
Yes,
sir.
sir.
Very clear. Very clear. I'm sure when we take the presentation, it's become more clear.
Okay, I'm already sending the slide. It's 10 megabytes. I'm already sending.
Wow.
Yeah. Dr. Conte, no, I can't forget you now.
Yes, Prof.
You're well done.
Look at it. Thank you so much, Prof.
Thank you so much again, Prof, for that, always coming into the clarification to some of these complex matters. We're always grateful. Thank you again, everyone, for coming for the presentation. Thank you, Dr. Charles. Thank you, Dr. Chibuike, also, for the warm presentation so far. So I hand over the class to Florence to give us final statement against tomorrow at closure. Thank you all.
Okay, thank you everyone for your patience. Thank you our chiefs, Chief Orimolade, Chief Okupi, and also Prof. It's been a pleasure having you around. Thank you so much. So tomorrow we are going to have MCQs all through. So it's just going to be MCQs we're going to do tomorrow. Thank you so much till we meet again.